Thank you. Ho-hum, here I am back again. Okay, I'll have my slides up. So my job is I'm going to talk to you about a different type of what we now call T-cell redirecting therapies. So Dr. Vij mentioned what a T-cell is. This is a very important cell in the body. There are actually many kinds of T-cells. We're not going to get into that right now. But he mentioned one way to deal with CAR-Ts, which is actually to change them, to use a virus to get inside the cell, have that T cell now express different things so that it will go after myeloma cells. But we're going to talk about a type of cellular therapy that doesn't require that is basically rapidly available to patients. So these are the bispecifics. And basically, the bi comes from the fact that these molecules, here's one here, here's another one, some of these have been referred to as bites. Their job is to be infused or injected, and then they pull together a myeloma cell and a T cell. So they will have different ends, these different sort of connectors that are essentially targeting, most of them right now just go after a protein called CD3 on the T cell, but they can be now shaped to target different proteins on myeloma cells. And Dr. Vij mentioned BCMA once again. That's kind of our primary target, but not for long. And you can come up with an idea that maybe we could start coming up with antibodies that can pull together myeloma cells and something else, like a natural killer cell, another type of immune cell. So most people think that these are going to be really developed in big numbers in the next few years. So we're going to talk about the one that is currently FDA approved and available, which is teclistamab in a minute. Dr. Vij mentioned the two commercially available CAR-T. Some of you, anybody here ever get belantamab? This is a drug that was around for a couple years, which I think actually was pretty useful. It did not meet a statistical endpoint in a trial, and currently the FDA pulled it out of the US, although it's still available in Europe. But these are some of the other BCMA-directed treatments, and we're going to look at some of the other potential targets on myeloma cells. Now, how these T-cell therapies are working is that we think they get they kind of get juiced when they find a myeloma cell, and they release, these are the various chemicals. There's granzyme B, for example, but it's these chemicals the T cells are releasing that not only lead to the destruction of the myeloma cell, but also cause the side effects that Dr. Vij mentioned, the things like fever and shortness of breath that you can potentially get not just with CAR-T, but with these bispecifics as well. So teclistamab is currently the only bispecific that's FDA approved. The approval officially came out in October, and the approval was based on a trial done in about 165 patients. Now I'm going to try to walk you through all these diagrams because there's a lot of stuff in here. But basically, this was a trial designed for people who had had a lot of different treatments for their myeloma. The average was about 5. And this medication is given as a shot under the skin in what's called step-up dosing. So you get a teeny little dose the first day, and then a couple of days later you get another one, a little bit bigger, and then on the third dose you get the actual treatment dose, and then it's given once a week. And to get back to Dr. Ataya's nurse's question, a lot of these patients did have extramedullary disease in this trial. Most of them were what we call triple-class refractory, meaning they had lenalidomide, pomalidomide, they'd had carfilzomib or Velcade, and they had an anti-CD38 antibody like daratumumab. But what got everybody so excited is this. So the response rate really, really pretty good. It's 63%. And that, in this particular group of patients, is quite high. So that means 2/3 of them are going to respond. But then what also got everybody very excited is that people who respond to these actually are doing quite well with them for a long time. So if you just look at how long, and this is again in people who've had a lot of treatment, how long do they do in terms of progression-free survival, meaning before they need their next treatment? it actually is very close to some of the CAR T data. So it's almost as good, and in some cases a little bit better. And also people seem to live a very long time for this group of patients. So this is really what led to the approval and led to a lot of excitement about this approach. Now, there's a bunch more of these coming. I'm just going to mention the next one that's probably in line to be FDA approved. This is a drug called elranatamab, which is another BCMA-directed therapy, another bispecific. This is yet another trial. Basically, what you would take away from this is these patients have had a lot of different treatments. One thing that we were talking a little bit about earlier outside is this particular trial allowed you to enter it even if you'd had other types of BCMA therapies. This is important. So about 15% of patients had either had belantamab or they had had a CAR T transplant. And this is one of the few trials that actually had a lot of African American patients, getting back to Dr. Cole's point earlier about making sure that we know therapies work at every type of patient. They had a lot of high-risk patients here too, which is important, and as I mentioned about the previous therapy. So the response rate here also almost identical to teclistamab, 64%. So again, 2/3 of patients. And what these arrows are meant to show you is a lot of the patients with these little arrows are still responding to the treatment after months. So we think that this is going to be another very good option. The same kind of long-term responses that you see in patients who are responding. So if you did have a response, you're going almost a year and a half before you're having to think about another kind of treatment. And so that's very, very exciting. Now, right now, and as I mentioned this, there was a question that came up outside about how does the FDA approve drugs, or what's the bar? If you look at the previous two therapies that were approved for myeloma people who've had more than 4 types of treatment, these were approved with 1/3 of the patients responding. And that's why I guess, or one of the reasons I'd have to say with what Dr. Vij presented and these drugs, these response rates are pretty amazing. We never used to have anything approaching this before where we could tell people, it's more likely than not you're going to respond to one of these treatments even though you've had your myeloma for a very long time, and maybe that you've had 7, 8, or 9 treatments. And again, this is why we really think these drugs, even though they are very expensive, as Dr. Vij mentioned, are really worth it. Now, there's a whole bunch of other BCMA-directed bispecifics coming. So we talked about teclistamab. I mentioned elranatamab. These are all, one of these is probably not going to be taken any further, but they all look pretty similar. They have very similar response rates. They have a little bit of variation in how many side effects they have in terms of this cytokine release syndrome that Dr. Vij mentioned, or the confusion, what we call, here is a mouthful, immune cell-associated neurological syndrome, or ICANS. So they have different rates of that, but I think we're going to have to figure out whether there are really any differences as these different bispecifics come out. So we'll see. Now, there's also going to be, we think, combinations of these bispecifics with other drugs. This is a study called the TRIM2 study. This is taking daratumumab and combining it with teclistamab. This response rate looks pretty good. There's one kind of caveat here, though, which is down here. One of the things that they saw, now this is a point I made earlier in the morning, these are targeting myeloma cells, but they're also targeting normal plasma cells. So the consequence of that is that patients really don't have any normal plasma cells around making antibodies. So in this particular study, these two drugs together had a very high infection rate, something that we're going to have to figure out how to manage, I think, a little bit better, but the response rates were pretty good. As you can see here, in some cases, the response rate at the top dose was 100%. So again, the balance here between side effects versus effectiveness, we'll have to see, but these kinds of combinations, I think, are only going to become more numerous rather than less. Okay, what about beyond BCMA-directed therapies? So there's talquetamab, and talquetamab is going after one of the other targets that Dr. Vij mentioned, GPRC5D. Now this is a protein, just like that diagram I showed you, that's on myeloma cells. This particular protein is actually on other cells as well, and it's on hair cells and skin cells and probably on epithelium to a certain extent, but it gives you another target if the other BCMA targeted therapies have stopped working. So in this particular study, a lot of these patients, if you look down here, had received belantamab. They had this previous CD3 antibody exposure, and a lot of these patients had revised ISS stage 3 disease, which we talked about being higher risk, and then again, to your point, a fair amount of patients with extramedullary disease. And once again, they showed a really pretty good response rate for a subcutaneous medication, 75%. Now, one of the issues, though, with this particular drug is that, I just wanted to make this point, too. So what about if you've had another B-cell maturation antigen drug and you got talquetamab? They had a very high response rate with this. So when this comes up, when people talk about the term sequencing, if you say, well, if I go through one drug, what can I do after that? Talquetamab looks like a drug that we will probably be able to use if you've had a CAR T transplant before, or maybe you got this other drug, teclistamab, or maybe both, because these response rates are really so good. And again, they last a long time, a little bit over a year, which doesn't seem like much, but pomalidomide, who here has taken pomalidomide? Anybody taken pomalidomide? That drug got approved with a duration of response of 4 months. So even though it's a great drug, these kind of response rates are way beyond that. And so, we really think that the introduction of these are really going to help a lot of people. Now, if we're looking particularly at people who are getting different doses of these drugs, they look, they actually look like even the higher dose is doing a little bit better. And like I said, duration of response about a year, which looks pretty good. Now, what about safety for these? A lot of bispecifics, or maybe most of them, if not all, as Dr. Vij, I'm not sure if you mentioned this, these kinds of cellular therapies, for reasons that are not completely clear, are a little bit hard on your blood counts. So many people, just like if you had a stem cell transplant, get a very low white count, they get a very low platelet count and a low red cell count, and particularly after CAR T transplants, sometimes that lasts for weeks to months. So you do see these kinds of blood cell effects with these kinds of drugs. The infection rate, interestingly, because it's not BCMA directed, was a little bit better. So that may be something that we'll keep seeing more of. But there are some special side effects of talquetamab that I think we're going to have to figure out how to deal with better than we know right now. And that is because of the fact that this protein is on skin and nails, people get side effects related to those. I'm going to show you a picture of this. And then they get this thing called dysgeusia, where they actually will have sort of a sore mouth or have trouble swallowing. And that is an unpleasant side effect, and people have said, well, how do you deal with it? We will tell people to have, drink more with meals. It looks like if you space out doses of the drug, that's going to be a good way to handle this in the future. But I think that this is something that we're going to have to very carefully figure out. And this is a picture of a person, this is just published recently, this is a person whose hands are peeling, showing you an effect of talquetamab, and then showing you some of this nail stuff where they get changes in the nails and lose nails in particular. So it's not, it's not dangerous at all, but obviously it's very annoying. And then you would say to this particular patient, okay, is it worth it if we can control your myeloma? Are you willing to endure these kinds of side effects? And the other thing that's interesting about these drugs is that neurological stuff, it looks to be, maybe pretty low with this particular product compared to some of the BCMA-directed ones, but I think we'll see in the future. Besides talquetamab, there's another antibody, a bispecific antibody, cevostamab, that targets FcRH5. This is also a protein that we have absolutely no idea what it does, but it is on myeloma cells and not on a whole lot of other cells. This has been in sort of a smaller groups of patients so far, also a very high response rate, and something that probably is going to be brought forward again soon, a little bit more ICANS with this particular product. Let's see. And, I don't know if I'm at the end. I may be at the end. Okay, so that was just a whirlwind tour through bispecifics, and having these drugs, just like CAR-T, we think are a great option for people, particularly those who are running out of different treatments. And as Dr. Vij mentioned, we expect to see these drugs used more and more earlier lines of therapy. What remains to be seen is what's the best way to do that, and matching and monitoring the side effects of these drugs to make them safe and capitalize on the effectiveness. So I think that is my last slide.